Alrighty, hello and welcome everyone to our SHRT Project Help webinar on the Revenue Cycle Crisis Management Coronavirus COVID-19 webinar. The original topic for this webinar was going to be part 2 of the ChargeMaster webinar series. That has been rescheduled for 3/31. We appreciate everyone's flexibility and our speakers today for putting this together. My name is Andy Naslin, and I'm the Small Rural Hospital Transition Project Program Coordinator at the National Rural Health Resource Center. You can see there's 2 polling questions on the screen. Please take a moment to answer them. The bottom question we ask at the beginning of each SHRT Help webinar, and the top one we'll ask at the end of the call, again, to measure knowledge gained during this presentation. After this presentation, we'll provide you with a link to our short online assessment. If you would like one ACHE qualified education credit certificate, please fill that out, and I will follow up with you. At this time, I would like to introduce you to our speakers, John Bain, Lori Daigle, and Lori Baudreau. John is Stroudwater Revenue Cycle Solutions President. John Bain has over 25 years of experience in healthcare financial management and consulting. His focus has been on ChargeMaster auditing, revenue cycle initiatives, hospital physician practice management. He has an extensive experience with solo practitioners, large group practices, small community hospitals, and large academic institutions. John has led initiatives to increase physician and departmental productivity, to implement physician-specific and hospital-wide revenue cycle protocols, and to develop ChargeMaster maintenance policies and procedures. He has successfully grown gross revenue and net reimbursement through combining operational improvements, ChargeMaster effectiveness, and efficient business office protocols. Lori Daigle is a certified professional coder with over 20 years of experience in medical insurance claim processing, medical billing software training, and healthcare financial management. She focused on coding and business office auditing and training initiatives, revenue cycle improvement, and hospital physician practice management, and research and development of periodic updates to support coding, billing, and other departments in compliance with regulations and requirements. And finally, Lori Baudreau has over 30 years experience working in the healthcare industry. She is the Vice President, Clinical Financial Resource Corporation, also known as CFR, which provides services to hospitals as well as physician groups in areas of medical coding, professional billing, case management, and clinical documentation. She is an AHIMA certified coder as well as an AHIMA approved revenue cycle trainer. On that note, I'd like to welcome our speakers. Thank you for presenting on such a timely topic. And John, if you're there, I'll turn it over to you.
Terrific. Thank you very much, Andy. And I just wanted to take 3 seconds and just thank you, Andy, and the staff at the center for really, working with us on the fly here to put some information together that I think is going to be really helpful to a lot of hospitals. But all of this was done with a lot of cooperation, I think, across a lot of different people within organizations. So I want to thank you guys for your efforts, and I'm sure that through this live presentation, as well as the rebroadcast of the recording, hopefully we're going to be able to help an awful lot of people here today. So with that, I want to thank everybody for taking a couple of minutes out of your day-to-day to join us to have a conversation that is surrounding sort of a topic that, in a way is very much unprecedented in our industry. I mean, a lot of times we go through some financial crises and stuff like this, but here we've got really an occasion where all of the potential things that might happen in the industry are all kind of culminating all into one. And what we wanted to do in this presentation is combine the resources that we have at our disposal to try to help you have some really specific processes in place to be able to go and address things, to be able to take components of this presentation, bring it to different people in your organization and ask, do we have this covered? Or what do you think about? Or how should we address this? So what we ultimately want to do is, as we're going through the different stages of this presentation, we want you to take these pieces, use them, I'm hoping that it'll challenge you to think a little differently when it comes to your revenue cycle and help your coders, your business office, your department heads, because ultimately what we want from a revenue cycle is for it to produce excellently, but at the same time we want those resources to augment the wonderful clinical care that you're providing your patients, and we want those things to work in balance together to really help ensure the financial viability of our organization. So we've got an awful lot of ground to cover today, so we're going to hit right into this. So what we're hoping to do through this is we want to make it so that you have the ability, whether you have done this already or you're working towards it, it is critical for you to be able to, within every hospital, to have internal revenue cycle management controls, because what you focus on and measure is what's going to help you move your course of your hospital along. So it becomes really important for you to have those in place. We want to talk a little bit about the importance of having sort of the central body, what we like to call the Revenue Cycle Steering Committee, who is helpful in trying to help set those controls in place. We're going to get very much into specifics on some best practices surrounding coding, and we're going to bring you some really, up to the minute type of questions that are coming from the field. We really are lucky today because we've got two coders that are part of the conversation that we're going to have, who have a wide breadth of information and knowledge, but also are dealing with this with hospitals and physician practices across the country. So we're lucky to have both Lauries with us on this call. We're going to talk about telehealth. That is something that is on everyone's top 5 topic list right now, trying to figure out how to understand it. We're going to try to pull things back and try to help you better get a grasp of things. And one of the things that we may not be very good at right now, because we've never had to do it, but we got to talk a little bit of how to manage staff who's now participating and helping within our revenue cycle, but is doing so from home. So there's a different skill set and a different set of priorities that need to be in place to be able to manage those resources effectively. So as we move forward here, we need to make sure that our revenue cycle is really up to the challenge. And as we're seeing across the spectrum here, there are changes in variability, both in utilization, patient flow, payer mix, all of these pieces that at times hospitals struggle with individually are now all coming together, and they're all becoming part of this large puzzle that we're all trying to fix. Okay, so what we want to make sure is at the end of this, we want to make sure that your revenue cycle is primed to provide timely and consistent information to allow your leadership to manage and anticipate cash flow and customer concerns. So as we start moving forward with this, we want to make sure that we're managing our processes, but at the same time, we're also doing everything, like we always say, through the customer's eyes, so that we understand what the outcomes are going to be, okay? And as we start going through, one of the things that you'll find is that both Lauries and myself, we've had the opportunity over, the last couple of decades here to be involved in an awful lot of revenue cycle types of crises. Now, granted, this is an unprecedented one because it's combining, the clinical aspects of things, but what we've tried to do throughout this presentation is pull what we've seen in best practices, regardless of the size of the hospital or the physician practice, and give you steps that you can take to try to wrangle things together and to feel as though you have a little bit of control in the situation, okay? So as we go through, what are we hearing from the field, okay? So we're seeing dramatic changes in variability and utilizations. In the very beginning, what we started to see was a lot of your emergency room volume. People were heeding the recommendation to not show up at the hospital if you weren't truly sick. So what ended up happening across the country, emergency room volume, especially those urgent care type visits, just started plummeting and falling through the floor. Then all of a sudden, people started getting a better understanding of what the virus entailed, and now we started to see maybe a little bit of a pickup in people who started to think that they had the virus. So there's a huge amount of variation. Likewise, what we're seeing is that and I just was listening to it seems like we have a news conference every 15 minutes. There has been, with the American Surgical Association, the Dental Association, a call that's gone out nationally to all hospitals and all providers to cancel all non-emergent dental and surgical procedures. So that's come out. That's something that they just announced a couple of minutes ago on one of the out of CMS, that they're requesting everyone to do that. So again, that is going to start limiting our volume, but also creating this bubble that we have to make sure that we understand. Eventually, this is going to come to pass, and we need to be ready and able to assist our patients in the rescheduling, in the addressing of their concerns, all of that stuff. So we got to deal with things as we're going along, but we can't forget that all of this stuff eventually will pass, and we've got to be ready for that. We've seen a huge push on the reduction of initial chemotherapy because people are concerned that they'll start the treatments and then develop some type of symptom that might interrupt their treatments. We've seen a huge drop in physician office visits, which is obviously contributing to a drop in ancillary services, whether it be MRI, CTs, labs. So we're seeing just a collapse of the outpatient volume throughout the country in most hospitals. And clearly, all of those components together have a tremendous impact on your cash flow. Okay? So we need to make sure that everyone's addressing both the clinical crisis and to manage the financial implications. So we're not going to get into or suggest in this presentation how you should be managing it clinically. I mean, you guys are expert in what you're trying to do here. What our goal is to make sure that the business side and the revenue cycle side is there to support those clinical activities. Okay? So let's be very clear. The revenue cycle has to be performing exceptionally to ensure the financial viability of the organization. Okay? We cannot afford claims to not go out. We can't afford for the revenue cycle inefficiencies to get in the way of claim submission. Okay? So daily revenue cycle management must be incorporated really, and what we suggest is that you establish what we like to call a revenue cycle steering committee. So at a minimum, we want to get together, and sometimes this kind of coincides with what you've got for a clinical perspective, but obviously there's a couple of interchangeable parts here. But we want CEO and CFO. We want the rev cycle director. We want the business office manager. And at a minimum, we want the emergency room director, RAD director, lab, and if you've got physician practice managers or support people, have them as part of this grouping. And to be clear, this team needs to be separate and distinct from the clinical management team. We want clinical to deal with clinical, and we want the business side to deal with the business side. The revenue cycle steering meetings, they should really be scheduled for about an hour. They should be daily, and they should be scheduled at the same time every day, which will allow the components and the members of that team the time necessary to accumulate the information that we're going to talk about and be prepared to present and give you the information that's necessary to manage your hospital here. So the revenue cycle meetings, they need to be agenda-driven. So we're going to limit it to 60 minutes because if not, you could talk for 2 hours, okay? We need to be sure that it reflects the areas of administrative priority, okay? So again, what you measure and what you focus on are the areas that you will have the best ability to manage, okay? So part of this is what we really have, in our experience, have seen real great success in surviving some of these crises, is really looking at volumes and having some historical comparatives that are available. But we want to look at, what is the current scheduled outpatient visits? Do you have any that are happening? Are people coming in and doing any type of that activity within our hospital? If they are, what are they? Where are they coming from? And are we sure that we've got all of the components set to make sure that we can provide that great care to the patients, but also recognize the revenue moving forward? What's our ER volume looking like? How many patients have shown up? What kind of patients are showing up? What is the mix of patients that are leaving and going home? Which ones are being admitted? And if they're being admitted, where are they going? Are they going to inpatient status? Are they going and being placed into observation, for example? So we need to understand that. What's our census looking like? Okay. Likewise, what's our claim submission volume? A lot of times people do not look at this, but it is critical, especially as you've looked from where you were to where you've been. You may have a whole host of claims that have been for previous dates of service that you haven't sent out yet. You need to be sure that you are current. You need to manage the number of claims that are leaving, and as you hit that bottom number where you get to the steady state of what your current reality is, you need to then continue to measure as you start coming out of it what that volume is looking like, so then you can correspond that to potential cash flow. Okay? What's our daily cash receipts? So clearly we're still getting paid today for activity that happened 15, 30, 35, 50 days ago. We need to manage that. We need to see who's paying us. We need to see the frequency at which that is coming through. And at some point, the lower volume numbers are going to start interrupting that cash flow. We need to be able to have a visual for when that starts to happen so that you can have accurate measurements for your days cash on hand, and you can start proactively trying to run sort of the things up for how you want to address these things. You need to look at late charges. Hugely important. Right now, the revenue cycle can't afford any late charges. You got to have everyone working optimally. Codes, and Lori will talk about this in a little bit, but claims that are awaiting final distribution, so that are ready to leave but maybe are waiting for coding or waiting for a query or something like that. We need to make sure all of those are being addressed. Do you have clearinghouse issues or denial concerns? If they are, let's get them out there, let's talk about them, and let's make sure they are addressed quickly and efficiently. What is your process right now for AR management? If we're not adding a whole boatload of new revenue into the system, we need to be optimal in how we're addressing what is owed to us, and understanding that the payers are undergoing a lot of change as well, whether it be remote staffing or lack of staff. We just need to make sure we've got a plan for that. Don't forget about scheduling concerns. Now, granted, we want to be there for our patients. We're canceling services. We need to be sure that we're providing the same consistent communication to people about how to reschedule and then make the process as easy as possible when it comes to rescheduling things. Lori's going to talk in a couple of minutes about telehealth. There's going to be billing concerns about that. Let's make sure that you've got the right messaging out there, that you're not adding any anxiety to the process. Rather, you're adding an area of calm and competence from your revenue cycle, and you're helping people understand things best. Okay? So clearly, the revenue cycle meetings are dependent upon accurate and timely metrics. Some hospitals are great at this, others are not very good at this. We suggest you create a dashboard that identifies areas that are really important to you, and that each of these areas that we're talking about, whether it's the daily total revenue all the way down to cash receipts and clearinghouse, and whether or CT volume, MRI volume, these are all numbers that come from different people within your organization that can be reported up to the steering committee, and that they can be, when you put them all together, it gives you a picture of the current reality of health of your organization. So we take these things seriously, we identify and work through who's got the ability to get these numbers, and we want to make sure that they are accurate and that they are timely, okay? So work through, use this as a listing to talk with your revenue cycle management team, your steering committee, however you want to call it. Come up with what you'd like to control as your crisis management metrics. Get those together. Find out if you can get what would look like in January, what it looked like in February, what it looks like currently in March, and then if you have the ability, see if you can find Q1, January, February, March from last year, and then look at April from last year. So now you can figure out what potential budgetary issues you're going to have if the volume doesn't respond as quickly as we hoped, or if some of these issues kind of push out farther into the future. At least you'll have a little bit more of a practical appreciation rather than something that is, kind of theoretical, okay? So whenever we go through and we sit down and we have that revenue cycle committee sitting down and talking with us here, we want to make sure that you focus in on these types of bullet points. You want to monitor the changes by department. If you've got that historical piece, if you can list out the gross revenue by department and you can see exactly what historically we've done, whether it's by number of visits, whether it's by gross revenue, however you've got that detail, it's going to be hugely important because you're not only managing today, you're managing and getting ready for the rebound. And you need to have the ability to say to each other, when and how are we at steady state? What is the number that we have to get to be back to where we were, say, in January? And you need to look at that. We need to identify, most hospitals don't focus in on late charges. They don't look at that. You need to understand late charges by definition are charges that came in from your departments after the bill left. And we just cannot allow that to happen at all. When the bill drops, it's got to be complete and it's got to be perfect. We want to get it out, get it to the payers, and allow them to pay and get it back to us as quickly as possible. Any report that you have, you want to make sure, if possible, that your system gives you and incorporates both payer and patient status. It is important for you to see the delineation of revenue through the lens of patients and inpatient, OBS, what's happening out of the ER, what's happening potentially out of SDC. You need to have those buckets, especially when it comes to ancillary testing, lab and rad, very specific. We want to make sure that if there's starting a rebound that starts to come up and say you start getting higher utilization out of rad and lab, that could at times not be from outpatient. It could be because our census is up. So we want to be very specific. Okay? You want, if possible, to force your systems to give you those comparatives at the charge code level. You want to make sure that when you're going through, that if you can have that comparative to Q1 of this year to Q1 of last year, you can look at things and maybe even correspond that to activity at the AR management level, and you can start making projections of things. Okay? It is very important as well, if you've never paid attention to what your clearinghouse clean claim rate is, now is the time to do it. You should absolutely be at 90-95%. If you are at anything under 90%, that's because we're causing issues with the claims. That's a delay in payment. We need to fix that today, okay? And all of this combines that now you can start going through and you can start doing some projections, of what is the ER volume looking like. So we know that your facility leveling process is pushing out different levels. What's the impact on cash? We want to make sure, what's going to be the impetus and issue with the outpatient surgeries, and ultimately as well, what's going to happen, with the lower volume for all of our ancillary testings, all the labs, all of the RADs. One of the things that we'll talk about in a couple of seconds is that if you are one of the labs that's processing things for the COVID testing, what do you do? So we're going to transfer, so as we start talking about things, so it's very important to also understand that there's stuff that's happening on the coding side. So coding's world is kind of being turned upside down in a way. So you're asking people to do jobs necessarily that maybe they haven't done before, because we've heard some people who are not feeling well and they were historically my ER coder, and now they are out, and now I've got my ancillary coders who really focused in on, say, rad and lab, who are now jumping into the seat of the ER coder. How do we manage those people remotely? We're seeing a lot of things and questions around proper diagnosis coding. Likewise, we're seeing a tremendous amount of questions surrounding telemedicine. So one of the things that we want to try to do here with you is to lay out and eliminate some of the misconceptions that are out there surrounding telemedicine and telehealth, and make sure that people understand that not all of these terms are used interchangeably. So what I'd like to do is I'd like to bring Lori Daigle into the conversation and have her kind of help us understand a little bit better just what telemedicine and telehealth and the changes that are happening and the opportunities that you guys might have in the marketplace to be able to use those. So Lori, can you talk to us a little bit about this?
Sure. So I think everybody has been monitoring the news and hearing all of the changes come about. It's very confusing for the general public because there are differences between telemedicine and telehealth. And I don't think patients really understand that, and really lots of business offices don't understand that either. So the guidance that we're talking about that is changing all the time is really more around telehealth. We're going to try to understand the differences between all of them so that you can understand how to properly get your claims processed and how to help your patients understand what's coming about. And these things are changing very, very rapidly. Now, Lori and I were on the phone just before this presentation trying to interpret some of the new changes that are coming out. And not only is the guidance coming out, is changing rapidly, but the interpretation of the guidance is as well. So we recommend that you have somebody monitoring the websites at least daily. Be checking the CMS newsroom website, be checking the CDC website, be checking your top payer websites to see what changes they're making as a result of this big crisis that we have going on here. Telemedicine is a number of different options, one of which is telehealth. Telehealth is that asynchronous communication between the provider and the patient. The originating site typically has always been a facility or an office, and that's the thing that has been waived now. The originating site now for Medicare can be the patient's home. It does not need to be in a rural area like it used to be. That's not necessarily the case for Advantage plans or for commercials or even for Medicaid. So you'll need to check all of your other payers. The originating site that you would bill if you are the originating site for this service is Q3014. And that's all you get to bill if you are housing the patient and not the specialist. One thing to consider here is the Medicare guidance says you can have different locations. It doesn't say you must. So different MACs may interpret this differently, and it's really a good idea to understand how your state is interpreting it. Patients are 100% of the time interpreting it like I can do this from home. You want to make sure that's your MAC's understanding as well. When we talk about telehealth, it's the physicians that are located in the distance site has not changed. It can be physicians, nurse practitioners, PAs, nurse midwives, registered dietitians can also use that, and there's a number of other providers. Other than to go through all of them, I've attached a link here to the bottom that identifies all of the providers that are eligible for this distance site consultation service. There are different codes depending upon the location of the patient. So if the patient is in an office or an outpatient setting, which is the code that you would use if they were home, you're going to use the evaluation and management codes. ED and initial inpatient has codes, as do critical care, subsequent inpatient or skilled nursing facility. So you want to identify the type of service and the location of the patient to understand which is the best code that you need to use to represent the service you are providing. I've received a lot of questions on this saying, have the guidelines for rural health changed? If the patient is home and cannot get to their rural health provider, can rural health providers, even though they are not currently allowed to be distant sites, has that guidance been relaxed? I haven't seen anything saying it has. However, I have sent questions out to different MACs to identify this. I sent a question to CMS as well, but the response I got from them is they weren't answering it. So we're going to have to rely on MACs for guidance on that one. There is nothing right now to indicate that has been relaxed for RHCs. There are billing requirements for different payers. Everybody is requiring a place of service O2. Most payers are requiring modifier GQ for asynchronous technology, meaning the patient can be seen on one end and the provider can be seen on the other end, and everything is 100% interactive. Some payers are requiring different modifiers, like the 95 modifier, which is more the AMA modifier that kind of signifies the same thing. Some payers are even wanting GT modifier, which has been disabled by Medicare back in 2017. So you want to see what your particular payer requirements are around these relaxation of the codes. Now, although rural health centers and FQHCs cannot be the distant site, as far as we know now with this relaxation, they do have one code available to them, and that's this G0071. This is meant to be a brief communication, but right now it is all we have. It's the only code that we know of that an FQHC or an RHC can be paid if they are interacting with the patient and when the patient is in another location. Now, telemedicine is different from telehealth, but patients aren't necessarily understanding this. So if patients are calling, they need to be made aware of the changes. In order for you to be paid for a telemedicine service, the call must be initiated by the patient. It can't be related to any visit within the previous 7 days, and it can't result in bringing the patient in for their next available appointment or within 24 hours. Now, in this current environment, that's probably not going to be an issue because as much as possible, you're encouraging patients to not come in, at least the government is. So this code set may be an option for you, but the patient should always be aware if they are calling you and they are going to be charged as a visit, they need to be aware that they are being charged. There are different codes available for whether they're interacting with a practitioner like we would normally think of, an NP, a PA, a DO, or an MD, and other professionals, because some other services are having to be performed remotely now as well. So make sure that we're understanding the right code set. The providers that we would usually consider doing evaluation and management services, those MDs, DOs, NPs, and PAs, would use the code set 99441 through 99443, depending on the length of time of the service. All of those guidelines apply, that it can't be related to a service within 7 days or resulting in a next available appointment, etc. Other than that, they are time-based codes. There's another set of codes for what we call other healthcare professional telephone visits. This would be speech therapists, physical therapists, occupational therapists, registered dietitians, providing diabetes education, things like that. Not because there is nutritionists kind of fall on both sides of the fence here. But for these services, we're going to use this code set 98966 through 98968. And these are also time-based codes. These are the CPT codes, and this is more than likely what your commercial payers will be expecting for telephone calls. Now, Medicare has a different set of codes that we'll be talking about. For these telemedicine options, like I said, the payer still has to initiate the service. It has to be on a HIPAA-compliant platform, although that has been somewhat relaxed by the government, but not necessarily by other payers. It has to be a cumulative service within those days, and it's 99421 through 99423. And again, these are time-based codes. For online services by other healthcare professionals, we have different codes for CPT versus HCPCS. Medicare does not consider non-practitioners to be able to perform evaluation and management services. They consider them to perform assessments. So CPT and probably your commercial payers want this code set, 98970 to 98972. These are also time-based codes. Medicare wants HCPCS for the simple reason that they have changed the description to take out the word evaluation and replace it with the word assessment because they don't feel these practitioners are licensed to perform evaluations. So for therapists and other practitioners that might be communicating with the patients remotely, they want this code set, G2061 through G2063. Now, we also have this final brief virtual check-in code, and this is just for communication technology. Sometimes people will do this on their phones or send emails or something like that. This is intended to be a brief communication technology-based service. You know, people might be sending results from their phones, giving their sleep records and things like that, their heart rates, their own blood pressure from their phones. This code is G2012. This is meant to be a very brief medical discussion about the information they're receiving via technology. Now, different payers, as I said, have different guidance around these. So you want to be able to check your payers. I would check your major payer websites daily. This is changing constantly. I just took a look yesterday at a number of major payers' websites. Cigna, for instance, has particular conditions that they're accepting these telehealth services for. Patients with immunosuppression or chronic conditions, experiencing transportation challenges, etc. They may update that as people encourage more and more not to travel, So be keeping an eye out for that. Be looking at your payer websites daily. Aetna had a zero pay for what they call telemedicine, which we would interpret to be all of those codes. We want to make sure they're not interpreting that as telehealth. They're also saying people with diagnosis with COVID-19 will receive a care package. However, there is no diagnosis for COVID-19 right now. So we want to understand how they are handling that benefit that they're publishing. Anthem has a recommendation of telehealth, but did not have anything on their website indicating what all states would be doing with respect to telehealth. That probably will be more area specific. Blue Cross varied significantly state to state, so you're going to want to take a look at your own website guidance. Cigna says they're waiving all out-of-pocket tests associated with COVID-19. So what does that mean if the patient comes in suspecting that and actually has the flu? We need to understand what payers are doing about all of these things. Your business office really needs to understand this because you're going to want to be able to appeal denials based on the interpretations. And this guidance is evolving constantly. I recommend you have your billers go onto the websites that they're responsible for daily and provide an update to the team. I did take a look at United Health today as well. For Medicare Advantage, Medicaid, and commercial plans, they are waiving originating site restrictions for telehealth, meaning the patient can call in from home. So, but theirs use even modifiers that are outdated. So really be understanding what your payers are doing about all these.
Now that's terrific. Thank you, Lori. And one of the things I think this is perfect for is when we start talking about instituting your revenue cycle steering committee, this is the type of information that needs to come to that larger group, have a multidisciplinary discussion, and once decisions are made about what code sets your doctors may use, setting up all of the potential processes to support that, charge master, pricing, billing, get everybody on the same page. So, and this, like Laura said, I don't think we can belabor this too much. This is constantly changing. You need to have people who are empowered and are authorized to keep on top of this and keep reporting it so that we can stay on top of it. Now, one of the things that Lori mentioned, in her conversation here is that, there are certain confusions about diagnosis codes and availability of codes. And what we wanted to make sure of is that we spend a couple of minutes in allowing Lori Beaudry to go through and represent some of the concerns that she's seeing with her coders, but also with hospitals and physician practices across the country, and making sure that everyone has a better appreciation about what should happen and what the process is, both on an outpatient perspective and an inpatient perspective of what we should be doing and how we should be looking at our coders. So Lori, can you help us a little bit out with that?
Sure. Thank you, John. So as we know, the CDC put out some guidance on coding. Unfortunately, what they put out was just a list of codes and said these are the codes that you would use. So I think it's very important, particularly for the inpatient claims, to make sure that we've captured everything, that you get the highest paying DRG that you possibly can. And that really comes from coding any underlying etiology or multi-body system manifestations. It's important that the coders understand the sequencing of coding these underlying conditions. It's important that they understand that the codes that in diseases classified elsewhere are never permitted to be a principal diagnosis. And that goes for the A codes and the B codes, which is the start of where all of the diseases come from. You will see that coders will want to use that as primary, and they cannot do that. They need to code an underlying condition first. They use additional code. 2 codes required to fully describe a single condition that affects a multi-body system. It's important that they pay attention and that they code it correctly and that they add the sequencing correctly. So the principal diagnosis, your coders should know this, especially your inpatient coders, but the conditions established to be chiefly responsible for the admission of the patient's admission requiring hospitalization. They need to review the entire medical record to determine what the actual principal diagnosis is. This affects your DRG. It's important that they choose it correctly. For the inpatient, they code as if the condition exists, suspected, if it's probable, suspected, or they unconfirmed principal diagnosis. This is not the same for outpatient. This is inpatient only. If 2 or more conditions are equally met, the principal reason, the sequence is determined by the circumstance of the admission, the therapy of the treatment provided, and code first guidelines apply to indicate otherwise. Coding concerns.
So, and I think the, sorry, Lori, I think the slide for presumptive skipped. So if we could go back.
I don't think it was there, John. Oh, there it is. Okay, there it was. That's what I was looking for. So I think that this has caused a lot of concern, the word presumptive diagnosis. We see it on the news. We've seen the president talk about it. We have presumptive cases. What exactly are those, and how does a coder go about coding them? The most important pieces to that is that for an outpatient, so those are your ER visits where the patients were discharged. Those are your urgent care centers where the patient was discharged. Those are people that are seen at the doctor's office and a lab is sent to them. Those are all outpatient encounters. The new drive-up windows that you're going to be seeing, or the drive-up tents, I guess is better use of word, those are all outpatient, and you cannot code presumptive, suspected, or presumed. You need to code, in those instances, the signs and symptoms, followed by the codes we're going to go over in a minute with suspected being near somebody that has suspected COVID-19. Inpatient is very different. Again, they can code possible, they can code probable, and they can code likely. All of those can be coded. I find it very interesting. These are the inpatient rules. This is how it will be done. However, when we're reporting the active cases of what they are when they're discharged, they're going to be leaving with a positive COVID pneumonia, followed by the A code or the B code for the actual virus itself. So to me, it's going to be very interesting how we count how many cases there actually were, considering the coding guidelines on an inpatient basis. So here's the part of the list of the codes. So we have pneumonia that's due to the COVID, and they want you to use the viral pneumonia. You'll see that B9729 is the code that they're using for the other coronavirus. That'll always be a secondary code to the main reason, whether it's pneumonia, acute bronchitis they have code for, bronchitis not specified whether it was acute or chronic. We have lower respiratory infection. Unspecified or acute lower infection has J22, notice the B9729. Respiratory infection not otherwise specified, so if they didn't say whether it was acute, it's the J988, followed by the B9729. Acute respiratory distress, the J80 with the B9729 again. I think these two right here are the most common questions, at least from the outpatient coders, on how to code these. So suspected COVID exposure is the Z20-828. So if the patient has had contact and suspected exposure, they want you to use the Z20-828. You will always code the signs and symptoms as primary. The Z code will never be primary. But it will let the insurance companies know that this patient was in contact or suspected exposure. The COVID-19 ruled out after evaluation. This is a very interesting code to me, the Z03818, encounter for observation for suspected exposure. Does this mean that the patient's not sure if they were exposed but has the signs and symptoms? They've not come out with a full guidance on what they mean by ruled out. On an outpatient basis, you wouldn't know if it was ruled out if the COVID came back negative or positive until the patient is left 3 or 4 days later. So from an outpatient standpoint, the majority of the cases are going to be coded with the sign and symptom that they put, that the physician writes, cough, shortness of breath, fever, followed by the Z20-828 is going to be your last diagnosis on that claim. It is important. I do have, the very beginning when this really started, when the ERs were seeing cases, the coders were holding them, having looked at. Some of them you could see that a COVID-19 was done, but the doctor didn't mention it in his documentation at all, other than a COVID test was sent. So we've had to send them back to the providers, asking them to document that they think that the patient was in contact with it. They're busy, I understand that, but we still need to get the documentation for us to be able to code the Z20-828. it may be important that some of your coders go and work with the ER docs and give them some guidance on how we're going to be coding. And this was the B34.2, coronavirus infection unspecified. It will never be used for the Corona-19. These are all respiratory in nature, and therefore they are not unspecified. So again, we should educate the physicians to document the history of immunosuppressive therapy. It's important that they put that in there, especially the slides that Laurie was showing. I believe it was Cigna that only allowing certain patients to be treated and having a personal history of immunosuppressive therapy will certainly get that covered under those patients that have Cigna. So I think the next thing, John, do you want me to go right into it?
Yeah, well, I just have one quick question, just
Sure.
I think you made an important piece that, you know, the coders are really dependent upon quick and timely communication and assistance from the physicians to make sure that all of the ducks are lined up appropriately. Are you seeing that docs are understanding the sets of questions that are coming from the coders, or do we need to make sure that the coders are, you know, giving additional pieces of information to kind of instruct in this new world so that the docs are learning on the fly and are doing the best they can from a documentation standpoint? What's your feel? What are you seeing?
I'm seeing that the physicians are just stating that the COVID-19 is not needed at this time, or we're going to send the COVID test off. They're not actually telling us why, unless the patient had a travel-related illness. And those cases, they're saying the patient traveled and had exposure to COVID-19. So I have sent to the physicians that we deal with the list of codes and just told them to please let us know if you are suspecting it and you're sending the test off, to make sure, number one, it's allowed us to also work with the billing staff, because the coders will see that a test was sent off, but we won't see the charge for the code. Again, that goes back to the same thing you're talking about. It's not necessarily a coding function to look at that, but when you're looking at the record and you can see that something wasn't charged correctly with the U code or the 8000 series code, it gives the opportunity to the hospital to capture and get in the amount of money that they deserve. So it's
and to be clear, yeah, so you're holding charges. So this would stop you from finalizing your accounts. You need this information to get to a final bill, correct? Oh, did we lose Laurie?
We may have, John. Hopefully she'll get back on quickly. But yes, if we do not have enough complete information, the correct thing to do is to hold the claim and query the provider.
Yeah, and let me work through, and hopefully Laurie Bode will be back on in a second here. There's a huge difference in managing your staff remotely than you have them when they're working, you know, within close proximity to each other. And this is sort of a list of information that Laurie put together to really help you create a checklist on how best to maximize this opportunity. You know, so when we start having people that work remotely, it creates production, supervision, compliance, and communication challenges. So some of the things that we need to make sure that we're thinking of, we need to make sure that their home computers that they're using, they're password protected. We need to make sure that they log off the hospital site every time they leave their home office. You know, sometimes we've seen some things where, you know, people are trying to help with their kids and do all this other stuff. We just need to make sure that they treat their home office as the same as they're treating the security in their work office. We want to make sure that the coder emails when they're signing on so that the supervisor knows that the day has started. And if there's specific tasks that they're creating, whether they're work lists or work queues, then you need the coder to communicate directly with their supervisor to make sure that they know that they're complete and they're moving on. And most importantly, if there's issues that arise, that they communicate those directly. So some of the things that we just chatted about, if we're getting a whole bunch of cases that I can't finish the coding because the documentation isn't supportive, people need to know and take action, especially people who have access to the clinicians. If the coders take a lunch or when they break or when they sign off, again, making sure that there's an email trail of when all of those activities are happening. We need to also make sure, and we take this for granted, that the email service that you're using is secure and encrypted, especially since the coders may be sending very specific information that have PHI. We just want to make sure that we don't have any issues with that. There are a whole host of go-to-meetings and different type of collaborative web-based communication devices that you can have group meetings. And I think what you also want to do is focus in on communicate, and wherever possible, meet with everybody as a group. If you do have access to that go-to-meeting, have everybody come on so that people can share best practices and they can share what is what they found is successful and make it so that it's as a normal process in a very unnormal time. Lori, can you take a couple of seconds, because I think this is also evolving. Can you just chat real quick just in regards to the COVID-19 lab testing?
Sure, and I just want to add some thoughts to the previous slide as well. If you have employees that maybe have not worked at home before, you want to make sure their home office is secure. The computer's not being shared with other people. If they're employees that tend to write notes for themselves, that information is secure and away from other members of the family or other people in the household. Everything that is HIPAA protected in the office must be HIPAA protected out of the office. So we need to make sure that that's fully enforced upon people. Now, jumping into the codes with respect to the lab testing, a couple of different options have come out. The AMA came out with a code that would be effective March 16th of this year for infectious agent of specifically COVID-19. And that CPT is 87635. They do have a description. If any of you have access to the AMA's descriptions, they have a short description and a medium description and a long description. It's really a good idea to use their description or as much as will fit in your charge master for consistency so that everybody understands exactly what we're talking about. This is the AMA's medium description that I have shown here. Their short description basically just goes to the COVID-19 amplified probe technique. Now, Medicare has released HCPCS codes because they want to know whether the testing facility is using the CDC, some other test, or whether the CDC lab test is being performed. So they're using U0001 for the CDC lab test and U0002 for the non-CDC lab test. However, their codes are not available until April 1, and testing is going on right now. So it's up in the air right now what CMS will do with tests that are being processed right now. We have no choice but to use the 87635 code, and we'll see how they manage switching over to the U codes at April 1st. But it's something that we want to take a look at. For the U codes, I recommend using the AMA description, but adding in CDC or non-CDC. And you can truncate this if your system requires less letters. I kept this under 48. But if you have fewer characters than that, you can take out some of the redundancy of this SARS-CoV-2 COVID-19 to reduce it to the size that you need. For all of these, you want to use revenue code 302. That's the immunology revenue code.
Laurie, this is Laurie.
You're back.
I'm back. I'm sorry. My phone apparently thought I had talked too much. This afternoon, at the President's brief conferencing, they were talking about self-kits that people will test themselves and drop off. So, again, everything is evolving, everything is changing, and we may end up coming out with yet another CPT code or another U code for that, depending on the payer. So I just thought I'd mention that. That happened long before we had put this together, and that was at noontime this afternoon.
And
that's okay, John, sorry.
No. I was just going to say, this is, again, a perfect example about why you need a group that can come together, that can work through all of the different pieces of information and can make an intelligent decision about what you're going to do and how you're going to do it. CEO, CFO may not be in a position to make the difference and understand what charge master code they should use. And Lori, I think the other piece too is that with the AMA code, the reason why we don't have a fee schedule next to that is because it's all going to be priced and based on what the commercial payers are going to pay. So we need to make sure that people are on top of that and are trying to figure that out, correct?
Yes. Yep. Commercial payers will assign different fees for these tests. And that is not accepted by Medicare. so I could not pull a CMS schedule on it.
No, that's great. And then, Lori, can you take a couple of seconds and just talk a little bit about when we start talking about, like I think you did a great job talking about the issues from a remote standpoint on the coding side, but I think a lot of the stuff also applies on the business office side and the challenges that staff is going to have as well.
Sure. And I think, oh, sorry, go ahead. Which floor are you talking to, John?
Lori
Daigle. This is Lori Daigle. Sorry about that. We need to change our names. So the business office, I think the challenges might be even of more concern than coding because they don't have the training. Coders are typically certified, and they've gone through a significant amount of training to understand the kinds of things that Lori was talking about, the sequencing guidelines, the code first guidelines, things like that. Business offices typically don't have that training. They've been trained internally, and they've been kind of making their own decisions on how to move forward. So if you are in a situation where you have to have your staff working remotely, it's going to be more difficult to manage this. You have to think about all the things that we talked about with respect to HIPAA and managing people's times. But we also have to understand their cross-training capabilities and how to monitor the kind of work they're doing. You want to take a look, as John had said, at your clean claim rates. Are they suffering as a result of all of this influx of commercial payers not understanding or not being in sync with the government payers? And also, decisions are being made so quickly right now by commercial payers and by government payers, we don't know if their adjudication systems are keeping up with the decisions they're making. So they may say they're paying things, but their adjudication systems are automatically still denying those things. So we need to have the business office understand the importance of keeping track of things and not accepting things on the first pass denials, understanding exactly what is going on. We're going to have issues with training and proficiency because these are people that don't have a really strong necessary background and certification in the go-to tool that they can refer to, the way coders do. So it's paramount that we keep more in touch with these people and to really make sure that we're supporting them. We want to, as John had mentioned before, it's really important now as businesses change, as the model is changing. We don't have the influx of cash from things like elective procedures. And if you're not having the elective procedures, maybe the patients aren't seeing the specialists either, so you don't have all the ancillary services. We don't have that cash flow going, so it's really important that they adjudicate properly and they capture every dollar they can. Somebody should be reviewing those clearinghouse edits daily and tracking by payer if you're seeing a change in behavior. So if you're seeing more denials by payer for different reasons, we should be looking at this by the volume, by the dollars, by payer, and by reason. And this information should be reported up through the business office manager and even higher if you're seeing changes in trends. We have to be looking at things like how are they handling all of the unlisted diagnoses that Lori just mentioned. Those are the only codes we have available to us, those unspecified codes, those other codes. How are they handling those? A lot of these payers are saying pre-authorization guidelines are being relaxed, but for what diagnoses? What if the patient doesn't have what you're looking for and what they're thinking of? So if you brought them in and you did the testing because of the eventuality, like Lori had said, we cannot code outpatient services based on presumed. So what are their guidelines if we don't end up with the diagnosis they were expecting? Don't let these things go to denial. Find a way to speak to the payers about these things.
Yeah, and just as a question, a comment to the two of you, I think this really, so the communication and the cooperation between coding and billing office has never been more important. I think making sure that we have an ability for everyone to understand the change in marketplace, but also to communicate back and forth to each other to address denials quickly and understand whether it may be of a coding issue or whatever. But I'm not wrong in that, right? I mean, so this is a paramount concern, especially since we're all working from home now. We need to find the platform where you guys can share and be on the same page, correct?
Correct.
Absolutely. And one other thing I wanted to mention, John, that is really important right now is Medicaid and what are Medicaids are doing, because that is state by state. You have an opportunity now to reach out through your networks to your state and see how they're going to handle things and what kind of waivers they will apply for. They do have the opportunity in this type of an emergency to increase payments. They have the opportunity to provide, to approve out-of-state services. So if you have people in your community that can't get home because of all the travel restrictions and you need to treat them and they have Medicaid from another state, you want to make sure you get paid. So you do have these opportunities. States can apply for these waivers. They can expand the limitations of coverage. They can add in different providers they're willing to pay. They can increase temporarily the payment structure based on this type of a crisis. So be reaching out through your networks to your states and see what kind of waivers they're applying for and what information they may need from you and your peers to be successful in those applications.
No, I think that makes all the sense in the world. So, as we start trying to draw this to a close, and I'm sorry, this is sort of like drinking from a fire hose, but, our goal is to try to give you, access to as much thought-provoking information so that you can make, informed decisions and really work towards, a solid foundation of your financial viability for your hospital. So just remember, the foundation of your revenue cycle, it is being tested, right? So we have to decide whether we're going to be up to the test or we're going to fall behind, because success will not be an accident. Hospitals that survive this and can come out better on the other side are going to be ones that made the decision to be intentional about it. Success is ultimately going to depend on clear metrics and full involvement. This is the definition of all hands on deck. This is if we've got a culture of us versus them, or we've always done it this way, or whatever it might be. Those excuses cannot apply. We must be that we are we. We are all pulling in the same direction. We are all concentrated on the support of our community, our hospital, and each other. Administration has to make sure that the access to data and the provision of information is a priority. If your system is something that's getting in the way, then we've got to find a way to talk to the system to have them not be an obstacle. We've got to make sure that the staff has an ability and the skill to monitor and stay abreast of changing regulations, payer guidelines, and policies. What Lori just said a couple of seconds ago is a perfect example of why that is so important. We suggest you implement a revenue cycle steering committee team to ensure that all of the aspects of the revenue cycle are measured and managed. If we don't bring a lot of these conversations up to the forefront to people, CEO, CFO are not going to know. And the more informed they can be as they have peer conversations, or they're talking to payers, or they're talking to government officials, they are more aware of some of the in-the-grass challenges, and they can be more effective. They can be better lobbyists. They can be, ask for more resources or more clarification. It is hugely important. You need to not forget that you're focusing on the impact to your patients. We need to make communication, rescheduling, and access simple and easy. Be ready, manage today, but be ready for what's going to happen tomorrow. We want to make sure that you review those telehealth and telemedicine guidelines and implement solutions that make sense to not only the organization, but also the community. Communicate across all of the platforms. Make sure problems are addressed and resolved. And as we always say, constant informed action is the key, and the only way to improve is to focus, communicate, and innovate. And one of the things I'd ask, Lori Daigle, you go first, and then Lori Beaudry, for from a takeaway, what's the most important, piece? If people are going to walk away from this, from your areas of expertise, what do we want them to walk away with, and what do we want them to do as a next step?
I would say for this crisis in particular, and to develop a model moving forward, is to have, John had mentioned a steering committee, and I would even, be more reactive than that and say maybe have a 15-minute huddle of your of these teams. Each biller should be assigned commercial payer that they're going to look at and say what changes have come about today. Somebody's going to be signed to look at billing. A coder should be looking at the coding website and say what news is coming out today in the CDC website. The finance should be looking at the changes, the reports, the business flow, and we should be having a kind of a fluid action plan. And equally as important, what's the message to your team? Because if you get together and you get that information together and you convey a consistent message to the team and to your whole facility, then people don't have that stress of wondering as much.
Oh, that's great. What about you, Lori?
From a coding standpoint, making sure that the coders are understanding what they're reading, making sure that the documentation and anything that they're reading, they can code. If they have any questions, see the provider. I know the providers are very busy. I do understand that. But if also you could work with the providers to make sure that the documentation supports it so that you can get the coders can get the claims out the door, because we don't want coding to hold up what billing needs to do so that the money can get into the hospital. But we need the documentation to support it. So work with the ED managers, work with the floors. If you have clinical documentation improvement teams, work with them so that they understand what you're looking for. Some of them are coders, and most of them should know this as well, but it's very important that we work together now. We no longer try to be separate.
No,
And in that vein, John, I just want to add one more thing. Lots of times I see a kind of a ping pong match going on. Billing will get back a claim saying, you know, this denied for this diagnosis. They'll send it to coding. Coding will say coded correctly. All of those things are true. These are going to come back because they're unlisted codes. If you send it back to coding, coding's going to say coded correctly because it is. That's not the right next step.
Incorrect. Incorrect conference room number. You entered 927. Please re-enter your conference room number followed by the pound or hash sign. Incorrect conference room number. You entered no digits.
We aren't receiving your number entry due to a possible issue with your phone carrier. Please hang up and dial another provided phone number, or try dialing from another phone. You can also visit link.gotomeeting.com/contact for support.
Code 6. Goodbye. Conference room number accepted. If you are the organizer, press the star key now. Otherwise, please hold. This line is now muted. This conference will now be recorded. For menu of available commands, press star 1. There are 26 participants in the conference.
But other than that, thanks again to our speakers, and thanks everyone for participating. We hope you have a good rest of your day and stay well. Thank you.
The organizer has disconnected, and this conference will continue for 60 minutes.